How long does it take for sensory complaints to resolve after nerve root decompression? You might think that given how commonly radiculopathy and its effects are seen in practice, that there would be clear data indicating prognosis for natural history and objective and subjective responses to common forms of therapy, and you would think that this would include not only objective measures such as residual neurological deficits, but also patients' sense of residual pain and improved function. Well, for the objective measures, there are some data with regard to how many individuals have residual deficits. However, for the subjective complaints of pain, numbness, and paresthesias, there are really none. Regarding objective measures, one recent study indicated that the majority of patients have a full resolution, but a significant minority continue to have problems with motor and sensory deficits. This study, entitled "The Efficacy of Systematic Active Conservative Treatment for Patients with Severe Sciatica," is just one example. Comparisons between those managed with a real versus sham treatment indicated that for the real treatment group, motor deficit equaled 14% at the end of treatment and sensory deficit 35%. At 1 year follow-up, motor deficit equaled 14% and a sensory deficit of 32%. For the sham treatment, at the end of treatment, motor deficits equaled 37%, sensory deficits 34%, and at 1 year follow-up, motor deficits were still at 30% and sensory deficits increased to 48%. Although the sham group was not a clean control group reflecting natural history, the outcomes are likely close when compared to other studies with control groups. What is interesting is that most clinicians have a sense of the answer to what symptoms recover for patients with radiculopathy, but the recovery rate of sensory symptoms like pain, paresthesia, and numbness after surgical decompression has not been reported in the literature. A small prospective study that begins to answer this question is entitled "How Fast Pain, Numbness, and Paresthesia Resolves After Lumbar Nerve Root Decompression," a retrospective study of patients' self-reported computerized pain drawing published in Spine in 2014. One might ask, what does this have to do with a chiropractor who doesn't use surgery? Well, two things. First, it allows us to convey to patients the likely progress of improvement after spinal surgery, but it also should reflect a sequence of improvement for our patients who respond to manipulation or other forms of chiropractic treatment, assuming the underlying cause of compression and/or inflammation is influenced. As usual, let's look at the criteria for participants. For the inclusion criteria, patients had to have had surgical decompression for a herniated nucleus pulposus and/or lumbar spinal stenosis with predominantly radicular pain, and that patients recorded their pain drawings preoperatively and at a minimum 2 postoperative follow-up visits during a 1-year follow-up period. For the exclusion criteria, patients had predominantly back pain complaints or degenerative scoliosis and spinal stenosis with non-radicular neurogenic claudication. Outcome measures included the Oswestry Disability Index, the short form 36, including the physical and mental component summaries, and a pain drawing. These were recorded at 6 weeks, 3 months, 6 months, and 1 year. Unique to this study is that the data, including pain drawings, were recorded using a computer program. This mobile device capture used a specific approach to pain which included different color codes to represent different sensory symptoms. Yellow indicated numbness, purple indicated paresthesias. For different types of pain, red indicated burning, blue indicated aching, green indicated stabbing, and brown for other types of descriptions. The magnitude of each sensory modality was measured by the pixel counts. Although these specifics about pain quality were collected, they're not evident in any of the reported results, nor are they correlated in any sense to the outcomes of treatment. In other words, the quality of the pain was not reported or indicated as the percentage of patients with a specific description of pain, nor was there a discrimination based on whether patients were herniated nucleus pulposus patients or stenosis patients. An important design of this study was to not only measure the mean differences for all patients, but to compare patients by dividing them into a short-term compression and long-term compression group. The short-term compression group represented 30 out of the 85 patients, with symptoms lasting less than 6 months. All patients in this short-term compression group had a herniated nucleus pulposus and had only discectomy. The long-term compression group represented 55 out of the 85 patients, with symptoms lasting longer than 6 months. 50 patients had lumbar spinal stenosis with or without degenerative spondylolisthesis and were treated with decompressive lumbar laminectomy with spinal fusion. Only 5 were treated for a herniated nucleus pulposus with discectomy. So in effect, this division or categorization created a measure of patients with a herniated nucleus pulposus radiculopathy compared to patients with primarily stenosis-related radiculopathy. So let's look at baseline pre-surgery complaints by percentage of patients. For pain, it was 86%. For numbness, it was 74%. For paresthesias, it was 45%. And for all three, it represented 33% of patients. Now let's look at baseline pain scores based on whether the patients were in the short-term compression group or long-term compression group. We can see clearly that pain was more severe on average for the short-term compression group or the herniated nucleus pulposus group compared to the long-term compression group or stenosis group. But let's look at the other sensory complaints. We can see for the stenosis patients, numbness and paresthesias are more severe compared to the herniated nucleus pulposus patients. After surgery, the improvement across both groups in the short term was reflected as a 55% decrease in pain, with numbness scores decreasing from 78 to 62 and paresthesia scores decreasing from 35 to 22. For the other measures, the Oswestry Disability Index score at baseline was a MENA of 54, improving to 44 at 6 weeks and then eventually to 34 at 1 year. The baseline mean for the physical component summary of the SF-36 score was 26, which improved to 28, then eventually to 34 at 1 year follow-up. The baseline mean mental component summary of the SF-36 score was 44, which improved to 48 and then stabilized. So the obvious question, do these small changes represent clinically significant changes for patients? Does it reach the threshold of a minimal clinically important change? Well, for the Oswestry Disability Index, absolutely. But for the 2 sections of the SF-36, just barely, and this is at a 1 year follow-up. Said another way, although we see changes in symptoms, it does not appear that function is consistently affected when comparing the Oswestry Disability Index with the SF-36. A very interesting and important clinical progression was that the slope of recovery of paresthesia reached a plateau at 3 months of follow-up, but the numbness recovery slope continued to improve slowly until 1 year follow-up. The mean score improvement at 1 year for pain scores was that they decreased by 65%. Numbness scores and paresthesia scores decreased by 37% each. A reminder that these are mean improvements, meaning that there are patients who experienced resolution while others experienced little change, but averaged, they represent these percentages of improvement. However, when we look at the 2 groups separately, a different rate of recovery between the 2 groups becomes apparent. All sensory complaints tended to trend toward faster recovery in the short-term compression group compared to the long-term compression group. Let's look at this graphically. Note that at 6 weeks, 72% of the herniated nucleus pulposus group resolved versus only 41% of the stenosis patients. The same is true for numbness, with 35% resolved in the herniated nucleus pulposus group versus only 12% in the stenosis group, and for paresthesias, 37% of the herniated nucleus pulposus group compared to only 19% in the stenosis group. So why the difference in time to resolution? Let's look at each type of patient separately, although there are some overlaps of effect. Neurologically, for the herniated disc radiculopathy effect, remember that there is a combination of compression with associated inflammation. The inflammatory irritation from the herniated disc may produce a state of hyperexcitability of the nerve tissue causing spontaneous firing. Removal of the compression combined with a decrease in the local inflammatory reaction may allow nerves to function sooner and symptoms to subside faster. For the stenosis patients, the effect is primarily mechanical compression, causing nerve fiber deformation and demyelination, the main reason for numbness and paresthesia. After decompression, regeneration and myelination take time to occur, delaying recovery even after mechanical compression is relieved. This may explain the delayed resolution of numbness and paresthesias compared to pain. So how does this apply to manipulation's effect? Let's take a couple of patient scenarios and consider some explanations based on the current study's results. If a patient with objective neurological deficits is seen chiropractically, it would seem that the best-case expectation is that the pain would first recede, followed by paresthesias, and then slowly numbness. If this was due to even an immediate decrease in compression, the improvement would take time, as illustrated by this study. But if the patient had radiation of pain without objective findings, it may be possible that the cause is not radicular and in fact related to a facet problem that, if corrected, could result in immediate relief, such as an entrapped meniscoid, aka locked facet. It is important to remember that facets can cause radiation of pain, but would not be the cause of objective losses of sensation resulting in numbness or muscle weakness, which is why it's important to always check sensory and motor function in patients with radiating complaints. So this study's results and some reflection allow us to sort out clinical elements and patients that are often combined. Here is a list of apples and oranges that are easy to combine if not being careful. Pain, numbness, and paresthesias represent different sensory dysfunction with different underlying neurological causes, broadly divided into compression and inflammation. This herniation patient's symptoms likely represent a combination of the two, but in most cases for less time than stenosis patients who represent more the compressive cause with resulting nerve deformation and demyelination. So, resolution of these complaints will be different, represented by a sequence of resolution, with pain being the first to improve. And finally, paresthesias and numbness taking time to resolve, with most of the improvement occurring in the first 3 to 6 months. Patients with stenosis have more complaints of numbness and paresthesias and have a longer time to recovery, with a lower percentage of patients with full resolution compared to disc herniation patients. So our expectations and the patient's expectations must be realistic based on the suspected underlying cause. Miracle cures of immediate pain relief are not likely disc-related but facet-related. The simple logic illustrated by this study is that it takes time even after compression and inflammation are removed for symptoms to improve. Patients often ask if their numbness and/or paresthesias will ever resolve. This study at least is a start in being able to answer that important question.